I've saved the most difficult question for the last, and it's for Dr. Sandler. And you know what it's going to be. It's cost effectiveness. This is something that practitioners ask me about all the time. They say, this molecular testing costs money. These new drugs cost a lot of money. Isn't this just going to skyrocket the cost of care? Is this cost effective? I have my own thoughts about this, but what do you think?
Well, fortunately, I have a PhD in economics from the London School of Economics. So obviously, I have no data whatsoever, but that hasn't stopped me before from talking. And I think that the concept that I would look at is if we've been using empiric chemotherapy in the metastatic setting for years, with some studies that have shown that there is some potential benefit, cost effectiveness, albeit these are more expensive, but we now have the targeted population where they do far, far better than the modest benefits with chemotherapy. So I would argue that they are or will be proven to be cost effective despite their cost because of the dramatic benefit that's seen both in terms of quality of life and overall survival as well, the impact that they have on survival.
Those with mutations are living on average 2 to 3 years. We never saw that
Right.
previously. It probably happened, but we weren't cognizant of it. And this is a readily identified population that stands to have a major benefit, not just in quality of life, but in survival, several living 5 years or more.
And I think the point is, you know, in EGFR TKI, the use of one is not restricted to the mutation-positive population. We can, I think the cost effectiveness in that situation between the mutant population and the wild-type population can be debated. In terms of the ALK population, I mean, you can only get the costly drug crizotinib if you are ALK positive, and that's 2 or 3 or 4%. So you're really excluding patients from expensive therapy. That's, I mean, maybe there'll be other roles for crizotinib down the road, but you're really excluding the majority of the patients who shouldn't be getting a costly drug because it has an undefined role.
And I took the question as for those that have a particular mutation or marker, not the general population.
Well, let me just say the way I also explain this to both patients and practitioners is that the molecular testing for the two prominent genes we've talked about costs about $3,000 to $4,000 on average. And a month of erlotinib costs double that. A month of bevacizumab costs 4 times more than that. So if you can identify a patient up front, rather than giving them empiric erlotinib, which could be harmful if they're wild type, is actually a cost-effective way. And that information empowers the patient, it empowers the physician, and it's, I think, the way we're going to be headed in the future.
Absolutely, I agree.
Are there any final comments before we wrap up?
Just thank you very much for inviting us.
Okay, thanks to the panel, and thank you for joining us.